Thank you all for joining us. Today's September 22nd, and we will be presenting will be about an hour talking about identifying hidden cash through data. And so my name is Ken and Rooney. I'm going to be facilitating this presentation today. The program is being recorded, so a little bit of webinar, the logistics, and a little bit about how to get the CPE on this event. So today's program is being recorded. We appreciate if you have questions or comments, put it in the chat, and I will be consolidating the questions during the presentation. So there is one CPE credit available for this session. So in order to get that CPE credit, you need to participate through the duration of this program. And then we do have polling questions that you need to answer during this presentation, and then that's how we'll be able to know they're participating, and then we'll be able to issue the certificates, the CPE certificates by email within 2 weeks. It's probably sooner than that. And then also after the presentation, you'll be, there's a survey that's going to be forwarded to you, and we appreciate any feedback that you have and any further webinars or webcasts that you would find interesting. So thank you for that. Okay. Today's presenter is David Hullum, and you can see David on the screen here. David is one of our healthcare leaders here at RGP Healthcare, and you can see very strong revenue cycle experience, as well as very strong data and system and technology experience. So with that said, David, I'm going to hand it over to you, and you can start us off.
Thanks, Kenan. Thank you, everyone, for joining us today. We hope you find our presentation meaningful and useful. And as Kenan said, if you have questions, please enter them in the chat. And then if you reflect on our presentation and you have questions later, please feel free to reach out, and we'll be glad to answer or schedule a conversation with you. Next slide, please. So today we're going to cover hidden cash, and we're going to talk about the components of how to identify hidden cash. So we're going to go over payment files and their components at a high level. We're going to talk about how to find cash using data analysis techniques out of those payment files. Then we're going to talk about identifying issues, trends, and developing strategies for harvesting that cash using this data. And then also too, the value of continuous monitoring and validation of the efforts that you've implemented or the changes that you've made in order to prove that the work that you're doing is actually reaping benefits. Next slide, Kenan.
Yeah, David, I would just comment real quick. I forgot to mention earlier, those of you on this presentation, attending this, one of our main things that we want to be sure that you leave here with is there's sometimes webinars that are very general. We're really going to dive into ways like David has shared here in his agenda that really get to the core of how you can identify, right, this cash, because it's the time right now that a lot of our healthcare organizations are facing these challenges, and it's a good time to really delve into this topic. So that's why we're kind of diving deep here.
Yeah. So this is a high-level overview of, a remittance advice or how the claim submission process works. As most of you know, the 835 remittance advice is the payer response to the 837s that you send whenever you want to submit a claim to get paid. The 835 remittance advice basically contains 3 elements. They contain payments, adjustments, and denials. And we all know that 835's remittance advices obviously contain more than that. But for us in this discussion, we really want to talk about payments, adjustments, and denials. Okay. Obviously, payments equal cash, adjustments equal correct contract terms. So in other words, you've got a contract, they pay you based on that contract, and they paid you appropriately. So those are correct contract terms. They also contain incorrect contract terms in the form of other payments and other denials that aren't specifically identified as a denial. And then we all know that a soft denial equals no payment until more information is received. And a hard denial equals no payment, and the only way you're going to get paid is to appeal. On the graphic there, obviously we see the flow from the 837 to the payer, and then the 835 remittance file back from the payer. I didn't put the intermediary relationship there, but I want to point this out. And this is where the data crunching is going to occur. An 835 remittance advice file contains 74 fields. Every remittance advice that you get is going to contain 74 fields. Doesn't mean there's going to be something in it, but there are going to be 74 fields. Right now, there are 291 potential CARC codes. And then within the CARC codes, there's another 1,053 potential RAR codes. So as humans, when we're trying to frap that kind of data in our minds and understand relationships and trends and things like that, it's very difficult for us to wrap our minds around that, because the 291 and the 1,053 that I just described, that's for one charge line. It's fairly rare for most healthcare organizations to submit claims with only one charge line, right? Next slide, Kenan. So when we dive deeper into CARC and RAR codes, we know that CARC codes are claim adjustment reason codes, right? As I stated, there's 291 codes which potentially explain payment differences for each charge line. Probably should have said each charge line instead of just one. Obviously, payers use this to justify payment or non-payment of a claim, or at least a charge line within the claim. And then really what I think of these as, these are just ways that machines communicate with one another about the success or failure of the charge submission or the claim submission process and the results of that charge submission process. So we're seeing alphanumeric codes coming back and forth, and that's the way these machines are communicating with one another and then translating so that we can understand what the results are. What this ultimately gives us is an accounts receivable transactions, where we're going to book the flow of these transactions into our ERP. We're also going to use it to do other things that we'll get into later. RAR codes are just a further dive into that. They're just a more refined communication process that provides additional information with further details about payment differences for each charge line. They communicate additional information as required, if any, okay? Next slide, please, sir. So this is our first polling question. Go ahead, Kenan.
You're right, I'm gonna go ahead and set the polling question off. So you all should see that on your screen right now. Polling question number 1. What are the 3 items typically contained in an 835 RA file? A, denials, adjustments, and refunds. B, payments, adjustments, and denials. C, charges, payments, and adjustments. And D, none of the above. So can you give me about 10 more seconds if you could respond, please? Great, thank you. Smart audience here. 100% of you. Can you here? Can you see the screen? 100% of you.
Nice.
Yes.
I hope I didn't make it too easy, but you know, who wants to rack their brain on CPE questions, right?
Right, exactly. Good.
Thank you, Kenan. So here's a transaction flow of the data. Okay, so if in our example we've got a healthcare organization that had 5,000 insured discharge claims and 15,000 insured outpatient visit claims. Okay, so 20,000 insured claims equals, for one charge line for each one of those. To simplify this, we're just going to say there's one charge line for each one. So that means there's 1,140,000 fields of data they're going to be sent via that 837. Okay, because there's about 50 some odd fields on those. It's going to go through the intermediary, and what comes back on the other side for us is about 1.5 million fields of data for those transactions. Because again, there's 70 some odd fields for 835s. What we care about obviously is the payments, okay? Because we don't have a problem if the payments meet our terms, and we're good with that. But in this example, what we're trying to show you is there's nearly 27 million potential CARC and RAR codes just for these claims with only one charge line. Okay, that's a lot of data. This data is extremely valuable to you. You should understand that this is the gold, right? This is what we're going to analyze. And in this example, if we see something for CARC 16, which means the claim service lacks information or has submission billing errors, there's an additional 306 possible descriptions that fit with CARC 16, okay? Next slide, please, sir. So pulling and extracting the data is just one part of the process. And this, what we want our clients to understand is that we should develop a bucketing scheme and a discipline related to that bucketing scheme where all CARC and RAR codes of a certain type will go into a bucket for analysis, okay? I think it's important, I always give this advice, it's important to understand the nature of physicians whenever you're using this information to drive change, okay? They typically don't forget anything. And if you're not using a very disciplined approach to bucket these types of issues, especially when it comes back to them, they're going to see that kind of discrepancy from time to time whenever you're showing them the data. And they typically sometimes will reject what you're showing them because it doesn't have any discipline around it, okay? So these are 6 suggested buckets. And what we want you to understand is that any of your rejected, denied, adjustments, whatever it is, could end up in one of these buckets and can be moved, because when we have multiple charge lines, there could be one charge line that falls into patient access and another charge line that falls into coding review, okay? Ultimately, what we want to do is we want to identify the ones through this process that are going to go to appealable, and that's where we're going to move them to, and that's where we're going to follow up on, and that's where we're going to get the money. So appealable is anything that we've already identified either straight off the face of the analysis as being something that we want to talk about and talk to the payer about to try to get them to pay. But the other 5, for all the way from CART, coding, patient access, patient responsibility, and unmatched, can all move into appealable or between one another as we start to work through the data, okay? The words at the bottom of each one of these chevrons are just examples of kind of the stuff that we would typically see on first pass, right? So the claim service lacks information or has billing submission errors, missing information, charge issues, medical necessity credentialing for coding. In the patient access area, we typically see, incorrect insurance, coordination of benefits, same with patient responsibility. But the last one is the one that most of my clients stumble with, okay? And this is unmatched and suspense transactions. So you can call them suspense cash, but anytime you've got suspense cash, you're going to have suspense adjustments, and you possibly are going to have suspense denials. So these are things that through the matching process that you haven't been able to identify as going to a patient service. Well, the reason why that is because we all know that on the remittance advices, you're getting information from transactions or claims that you submitted 3, 4, 5, 6 months ago sometimes, right? So you may have already adjudicated them on your accounts receivable and in your patient accounting system, but unfortunately the payer has come back and said, no, we made a mistake. We're going to take some of that back, right? So it's important to understand that there's a discipline around that as well. I could probably have another 50-minute webinar just on unmatched suspense, period, okay? Next slide, please.
Yeah, David, can I sit on this slide a second? Just
Sure.
a question for you. So the slide before, you talked about the number of codes that are out there and then they fall into this bucket. How do companies, do they tag these? Like, let's say that we set up a schematic of 1 through 6. Do they get coded as, is it an automated, or is there AI that decides if it goes into bucket 1, 2, 3, 4, 5, 6, or is this a manual process that puts it in? And then is this like a scrape off of it and then dumped into some kind of SQL or Tableau database, or like, what's that look like to get to here, to get this bucket?
So I'm glad you asked that question, Ken. So as I stated, there is a discipline that goes around this, and I'm going to go through one of the aspects of that here in probably the next slide or two. So there is some discipline around this, but you're correct. What happens is that as you accumulate this data, and when you accumulate it, when you're going to use it for your analysis, you want to make sure that you're defining where these are going to go on first pass, right? And then once you do that and humans intervene and review, then they make the decisions to move those into other areas. So you're correct. It doesn't matter whether you use Tableau or SQL, or you want to build a big giant Excel worksheet with pivot tables, whatever you really want to do, it's really up to you. We can support you and help you with that, but that's really, Ken, and you've got it exactly right. But
it's a manual observation. Like, okay, this is incorrect insurance information. It goes into number 4, and it's a
Right.
manual intervention to decide which one of these go into.
Right. Once you set the discipline up, though, you can build the analysis. So when all the raw data is accumulated, you can build the analysis so it puts it in the buckets for you. Okay. So it's basically it's a math equation. It says if you get this, this, or this, then it goes here, right? All right. So we're going to define what a denial is, and I hope some of you find this kind of humorous. Go ahead, Kenan. So a denial is the action of declaring something to be untrue or the refusal of something requested or desired. I think in our business, that definition absolutely fits because that's exactly what it is. It's a refusal of something that we've requested. Go ahead, next one. So in my world, it's the dirtiest word in healthcare reimbursement. Whenever I don't want to hear the word denial, but unfortunately, it's part of our business, and that's what we do. Next. You cannot find another industry in the world that deals with the reimbursement game that we play in healthcare. Okay, I like to say that we're guilty until proven innocent, and the payers hold all the cards. And the next chevron, Kenan, we perform a service. I mean, again, you can use the grocery store, you can use an electronics store, you can use a gas station, whatever you want to use. We perform a service, and that service is billed against a contract. And the payers get to decide and provide a justification that we have to disprove in order to get paid what we're supposed to get paid. No other industry it works like this. Okay. Next slide, please, sir. These are denial types and reasons: hard denials, soft denials. I've kind of gone through this already. These are some of the categories: missing information that we see the most. Okay. We consider most denials to be preventable or avoidable. Okay. I mean, that's just basically all denials, in my opinion, are preventable or avoidable. Okay. If you're doing things the way you're supposed to be doing and your contracts are set up the way they're supposed to be set up, the thing is, we know that the payers change their terms, and so they fall into those buckets, right? I think what's important from this slide that I'd love for you to take away is this: underpayments are sometimes categorized as adjustments that are taken, or that's what they are, right? But they're really a soft denial if you think about it. And so I want you to think about this concept. If you've got two different groups that work underpayments and denials, my question to you is why? They're really the same thing. And their levels of effort and the information that they share together and the way they work together is they basically are doing the same thing. It's just one's appealable, you know, where you've got to go through a formal process to make that appeal, and the other one is kind of more ad hoc. Next slide, please, sir.
Great. Now, next polling question. Move to polling question 2, launch. Polling question 2. What is the truth about adjustments and denials? A, they cannot be completely avoided. B, their reasons change constantly. C, they take time to work. And D, all of the above. Great. Yep. There it is. Yep.
Very
Correct.
good.
All of the above.
All right. So this goes to what you were asking about earlier, Kenan, which is, you know, here's the methodology for identifying, tracking, trending, and some of the tools that you can use to do this. Okay. It is absolutely important, as I've stated earlier, to categorize adjustments and denials. So you want to build and define the work list or the work queues that put similar items in groups. Okay. Again, you'll thank me later for this because you're going to have those physicians. They're going to make these inquiries and they're going to want to know, well, why is this here and why is that there? This is the part, Kenan, that really interests me. Okay. When we go to clients and we talk to them about their CARC and RAR codes and what those mean, there is a defined definition of a CARC code. There's a description that goes with all of them. They're all the same. It's a uniform description. Okay. Same thing with the RAR codes. But the way organizations treat those is where this is where the problems exist, right? I've talked to a number of CFOs, and those CFOs, I've heard from many of them who have said over the years, as I'm helping them and working with them, that they don't even look at adjustments ever. And the reason why is because, well, I mean, we have a contract with them. They said it doesn't fit the contract terms, so we're not going to get paid. So why even waste any effort with that? Well, folks, I'm here to tell you that that's where all of this hidden cash is pretty much hiding. You can't take their word for it. It's your cash. You should be making sure that what they're doing to reduce your reimbursement is legitimate, okay? Workflow visuals. I preach this constantly. A picture is worth 1,000 words. Do not type 1,000 words to describe the problems and the issues. Make a graph, okay? It's way more effective. And when you're looking at these kinds of trends and this information over time, the visuals are way more powerful. I'll tell you, I'm an executive. I'm a former healthcare executive. We have a very short attention span. We do not want to be told how to build a watch. We want to be told what time it is. So that's, kind of the methodology that you need to follow when you build the visuals, okay? Champions. This is probably one of the single most effective methods for getting change pushed through your organization, especially in the clinical arena. Identify champions in patient access, in billing, in coding, and then also in the clinical space with physicians that can help influence and win supporters of what you're trying to affect positively, right? These people can do your bidding for you. They can help change the theory or the thought process around some of this as just being a business office issue instead of being a whole organization issue, okay? Analytics, it is absolutely important that you track these adjustment denial histories over time. I always recommend to my clients a 12-month rolling average for all of this information, okay? You can do 13, you can do 16, you can do 18, but my advice is please don't do anything less than 12 because we want to see seasonality. We want to see trends that were, something happened, maybe it was a glitch or an issue, and then it gets smoothed out after the other months. But 12 months is usually around the sweet spot, okay? Also, develop the methodology that when you see something pop up, it's an anomaly and you're going to pay attention to it. 2 months is now a concern. 3 months is a trend and you got to address it. So your corrective action should have already been defined in month 2. And when it happens in month 3, pull the trigger, okay? And then again, communications. Make sure that you understand your audience. Again, executives want to know the time, but the people down at the operations layer, they need to know how to build the watch, and they need communications, and they need analysis, and they need visuals that fit their level of engagement. Next slide, please, sir. So here's where we talk about assigning responsibility, and this is how you're going to reach the organization, or how you should reach the organization in order to assign responsibility. So everyone that's involved in this, in billing and collecting, from the beginning to the end, has a role. And when we talk about assigning responsibility, it's not just from taking ownership perspective. There are some cost drivers that are associated with this responsibility. And I want everyone to understand that, because we're going to go through an exercise in a minute related to cost drivers, okay? Obviously, providers, the thing that we want to provide them is education. We want clinical documentation improvement. We want coding improvement, but we provide them with education because we're trying to drive consistency, okay? In the patient access area, it's really the same thing, but the big issue here is understanding from each payer's perspective when you have to have coordination of benefits and when you are going to identify what the patient responsibility is. I could do another 50-minute webinar on patient education as it relates to their responsibility and the value that you get from investing that time on the front end, okay? HIM, coding, billing, really pretty much the same thing. We're providing education. The one thing I will say about billing is if your scrubbers and editors, if you're receiving denials and adjustments on the back end that your scrubbers and editors should have caught, there's a problem with your editor, okay? That is a fail-safe. If stuff's coming through, then your editor or your scrubber did not catch it. You need to reconfigure your scrubber, and you need to work with your vendors on those scrubbers to make sure that those configurations stop those things from happening before they go out the door, okay? Finally, this is the one area where I find a lot of our clients don't engage the organization that contracts with payers for services. We are never providing the people in the OGC or the contracting area with information that shows the success or failure of collecting the cash. We need to be providing them with this information and enlisting their help to say, we've got these contract terms and they're not being paid appropriately. Can you please reach out to your OGC folks on the other side and say, help me? The other piece of advice that I'll give you is that when you have these payers that are what I call problematic, frequent flyers of issues, you really need to have a meeting, a sit down, invite them to your organization and invite their medical director and their payment processing folks to come have a sit down and meet your staff and talk about the problems and the issues with your medical director, their medical director, and then your reimbursement staff, okay? That helps a lot. I've seen it repair relationships and it's effective. Next slide, please.
David, can we stay on the slide a second? I'm curious if you could share just maybe what you've seen on, I look at these are roles, right, within an organization, and this whole conversation is about, you know, getting cash out of data.
Yes, sir.
Where are the opportunities like in this, I mean, I'm looking at these roles and I see pictures of people, but where is the opportunities that you're seeing, or where are companies, organizations going to try to find most of this cash? Is it within the clinical documentation area? Where through the data, or I mean, does that make sense? My question,
Yeah,
where is
no,
the opportunity, the low hanging opportunity, and then the secondary?
No, I understand what you're saying. So from my experience and my perspective, where I see the biggest opportunities to fix, if we think of this as a faucet that's on and it's running and we're losing money, right? So in order to turn that off, where I see the biggest impact is honestly the communication with OGC and contracting to enforce those payment terms with those payers so that they know you're looking at it. Because if you know your mom is watching you when you're doing something wrong, are you going to do that? No. It's the same thing if you're enlisting the people that negotiated the contracts. You're putting them on notice. Hey, we're watching this. And it really does a good job of affecting that behavior, okay? And the billing
is that where
area,
companies are investing in right now, David? Where are they?
no, they're not. I mean, that's the thing. That's the issue, is we're not engaging our OGC counterparts to help us in this arena. Okay. Next slide, please, sir.
And also, I just want to give a heads up. It's the bottom of the hour, so 30 minutes in. Please, if you have any questions, or put them in the chat. Here we go. Next slide. Only question number 3. How does the presenter, David, define a claims denial? The dirtiest word in healthcare. An action of declaring something to be untrue, or the refusal of something requested or desired, a river in Egypt, or both A and B? It's a trick question.
It is a trick question.
Yeah. All right. Hold on. Dog barking, everyone. That's my dog. I apologize.
Hey, welcome to the new world, right?
Yeah, everybody. 63%. The answer is D, both A and B. I think they got caught on that. A and B, everybody.
Yeah, it's A and B, but it's okay, because those that answered A and those that answered B are technically okay. It's just both of them, right? I'm glad no one decided that it was a river in Egypt.
River in Egypt. If they did, we would be taking names.
All right, Kenan, next slide, please, sir. So the value of using analytics and analytical discovery, and this is really the value from this. This is the value prop, okay? Before, what we did was we did observation, we reviewed, we looked over your shoulder, we went through and watched your processes, but that's going to identify some process issues, right? It's not going to really get to the heart of why the payers are not paying, right? So we're going to find problems and issues in this methodology. But we're not using hunches, we're not using guesses, and we're not using previous experience. We're using your data. We're using the actual performance of your organization against that. So we don't have to invest in assessments anymore. We don't have to go through their very labor-intensive, time-intensive types of methodology. We can find out what the problems are using your data, okay? We want you to create large data sets, okay? The bigger, the better, because the trends and the analysis and what you can see from that is going to be very eye-opening for you, okay? And then the analytics from the results are going to identify issues, and it's going to quantify them by frequency, by volume, and by dollar impact. There is no more powerful result that you can put in front of a physician practice that's going to have these problems and issues that are attributed to them when you show them how many there were, how often it happens, and what the dollar impact of that is, okay? And it also allows you to risk rank. Now there's no more mystery around which one we should attack first. We've got the number and we've got the dollar impact. Those are the ones that we attack first, right? The reason why we say that this produces immediate ROI is because we're just analyzing data. We haven't gone through this whole entire assessment process where we've invested all this time and effort and everything else, and then we've made some small changes. We've frapped the data. Now we know what the big risk issues are, and we're going to go throw things at them to alleviate them and correct them and collect this cash, which means there's literally no hit to your EBITDA. So you haven't invested in any expense to do this. You've just gone and looked at the data, and now you're going to go recoup all these things that you're identifying as being underpayments or denials that have a very high ability to be collected. Next slide, please, sir. So this is just kind of a layout, a hierarchy of an example of how you use your data to identify issues. And it's going to step through the analysis and then the areas of responsibility and then what you do after that. So you could have identified coding issues, benefits issues, and then unposted transactions or claims that are in backlog, right? Your solutions for those could be a project to improve coding. So CDI, okay, clinical documentation improvement, and you launch a provider education program, okay? Well, the beautiful thing about this is that you're doing continuous monitoring of your 835 EDI files now, and you're going to do continuous validation of whether those efforts are actually having an impact, okay? In the benefits area, you may realize now that you need a patient access project. Just like I said a minute ago, I could spend 50 minutes talking about authorization and patient education. Well, these are projects that you would want to launch into so that you can now reduce the number of encounters that you're having that have those kinds of issues. And then in the unposted and claims backlog, you can invest in AR cleanup projects and then AR remainder programs. And I want to explain the remainder program for just a minute, okay? In your collection scheme, there's going to be a point at which your organization is going to have diminishing returns, okay? It's not a bad thing to outsource your AR at some point, okay? Because the economies of scale that a lot of these organizations have, and we have one as well, are superior to what you can do in your organization. You can't afford to have 100 people following up on all your Medicare claims all the time after so many days and below a certain dollar value. Your folks are doing the best they can to collect the 80% of the cash that they can collect within 45 days, okay? You should really consider thinking about moving the rest of those out because they're just going to the bottom of your queue as they get older, and as the dollar value gets below a certain threshold, they're never going to get collected, they're never going to get worked, and that's where the cash is. They've got problems, they've got issues, they've got incremental things that need to be responded to, they've got adjustments that need to be made. But because they're below a certain dollar value and they're aged out, your folks aren't working them. That's technically where most of the hidden cash exists, okay? So next slide, please, sir. Okay, so here's where we're driving home the value of communicating the results, okay? Issues tracking is you want to develop robust reporting tools using standard categories. I've harped on the discipline of doing that. I hope you all get it. You just want to define those things, and then that's how you're going to bucket them every time. Scoring, okay? This is an important aspect. And I know I'm picking on physicians, but you can do this across the whole entire organization. When you identify patient access issues, billing issues, whatever it is, assign the responsibility and score how well they've done from 1 month to the next. Because here's the thing, especially with physicians, they are very competitive, okay? They're also very results driven. I mean, they're caring for humans. The result that they want is a healthy patient. Well, also the result that they should want is a paid claim, okay? So when you put this information up in front of a practice plan and the medical director or the physician leader disseminates this amongst the group, you can see very quickly some of them are unhappy at being at the bottom of the list, and they may blame you, right? But ultimately what they're going to do is they're going to try to do what they got to do so that they can be at the top of the group with their peers, okay? Working groups are way more effective than committees. And the reason why is because they're small, they're nimble, and they're usually configured with people that are very knowledgeable about their part and their role in the process. So I would say leverage working groups as much as possible. Your committees are going to be your groups that are going to implement governance. So all these bad things happen, we need to put some penalties around there. And so you go to your committees to say, we need a governance structure, we need a policy related to this. And one of the most effective policies is billing hold. If you've got providers that are constantly submitting claims, that are having denial management issues, problems that you're dealing with on the back end, I have suspended physician billing privileges before, and it's not popular, but it's something that works and it's effective. But you should never do that on your own. You should leverage committees to do that, because then there's multiple people to blame for that and not just you, okay? And then finally, dashboards. We're going to go back to that statement that I made earlier, that you have to build your dashboards for your audience. An operations dashboard, you should never put in front of executive leadership. Management needs to see all the pieces of the puzzle that they're managing against, even some of the things that are upstream and downstream. At the operations layer, we want it to be detailed enough that they can see what needs to be done and execute against that, but they may not necessarily need to see some of the upstream and downstream effects of that, right? Next slide, please, sir. So here is a case study where we helped a client using data to transform their organization. Using their data, we were able to identify revenue leakage, cash acceleration opportunities, and workflow issues and solutions for those. So the challenge was that this was a $46 million outpatient rehabilitation facility that was part of a $1 billion healthcare organization, okay? So they had a rehab hospital and practice, and then all of the things that you would associated with rehabilitation services. They knew they were underperforming financially, but the overstaffing, scheduling issues, and charge capture practices, they didn't realize what those were. That's what the data drove. So we kind of jumped the gun a little bit on this description, but these were all negatively impacting their cash collections and the bottom line performance expectations of their organization. So what we did was we mined the remittance advice information. We assessed their client's revenue cycle program using that data to identify missed revenue capture, lost or missing revenue charge opportunities, stagnant accounts with viable collections, as well as mitigate major business process issues. As we found out, we come to find out as the number of visits that they have scheduled versus the ability to schedule, we found out they had scheduling issues. So we identified staff performance efficiency issues, which created additional revenue opportunities. Weren't using standard schedules. Each one of their providers had different schedules, and they all agreed that they needed to standardize those. The client developed remediation plans. They assigned priorities to issues producing significant impact and cash, and they obviously wanted to produce ROI, which we were able to help them do. We implemented an extended business office for them to clean up their AR. So we had a cleanup program where we were able to extract cash out of their AR, and then we set up a remainder program where we found the break-even part of the days in AR plus the claim value, where it made sense for them to outsource, okay? Redesigned their scheduling, deployed administrative and provider staff using a more efficient and cost-effective model. The ultimate impact of this was we were able to collect $1.2 million in cash within 60 days, and that was held up in AR with various issues. Now, I don't care who you are. You could be the biggest healthcare organization in the United States. You could be one of the smallest, but $1.2 million is a significant number. And here's why. It's been a while since I recruited physicians, but back when I was in practice, I was responsible for helping identify and recruit physicians to come work for the organizations that I worked at. Back when I was recruiting physicians, neurologists were about $500,000 a year. Well, using this cash methodology here, we've just produced an additional $1.2 million where we could provide them, if they needed it, they could have provided themselves with 2 neurologists and a brand new family practice physician for $1.2 million, okay? That has an impact on the health of a community when you're able to add those services and you got the windfall to be able to do it, because that's ultimately what we want to do. We were able to increase their net revenue by 19%, their cash collections from 19 to 43. We reduced their AR days down to 37. Their labor compensation ratio was now 3%. It was reduced it by 3% because they were more effectively using their staff. And overall, they realized a 6.3 times ROI on the project. Next slide, please, sir.
Next polling question 4. Which group is primarily responsible for avoiding denials? Providers, HIMSS coding, denials management, all of the above. Thank you. It is D, all of the above.
Yep. Right now we're coming down the home stretch. So trouble claims and strategy response. Again, track, and continue to track appeal deadlines. This is the most important thing. If you've got the ability to appeal a denial, then you should always make sure that you understand where you are in the denial appeal process and what your deadline is, okay? You want to ensure that your responses that fully answers the cause of the adjustment or the denial. And you want to have a quality assurance review. I'm not recommending that you have 5 people look at these before they go out the door, but a second and third set of eyes is always helpful. I love the peer review part of this. If a coder is looking at a denial and building a response to that, they can always have a peer coder review it to see if they agree with the way they're doing it, and then have a supervisor look at it before you send it out the door. Okay. All statistics related to denials, soft or hard denials, indicate that quick and complete response times to claims issues have a greater chance of success. The other thing is payers know who are working these, okay? And if they know that you're working them, they're less likely to be aggressive with you on some of these things. I'll tell you, I've got colleagues that work on the payer side of this, and they tell me all the time that they are constantly devising ways to keep money within their organization. If you don't believe that, I don't know what to tell you, because it happens every day, okay? And then you want to employ aging techniques as a method to understand trends. None of my clients do this except for the ones that I've shown this to. And then once they see this, they love it. So I'll step into an example of that in just a second. Next slide, please, sir. So we talk about cost drivers when we're relating to denials and adjustments. And I'm not going to spend a lot of time on this, but I want you to understand there are cost drivers associated with denials management across the entire organization, okay? Providers contribute to it, patient access contributes to it, coding, billing, and contracting, okay? Tools and contractors also need to be including when you're identifying cost drivers. So when you've got a denial and you need help from any one of these other departments or areas to do this, you've just increased the cost of actually working that denial, okay? It's just like a manufacturing firm. Anything that you do that adds value or adds time and effort to it raises the cost of being able to collect that, okay? Next slide, please, sir. This is a very simplified way to attribute cost to working a denial, okay? If you look at your rows, you've got denied dollars, you've got the FTE time to work the denial, You got the time the FTE spends with whoever the FTE is, educating whoever they need to educate. You've also got the FTE time in reporting, building the reports, disseminating the reports, responding to the reports, et cetera, right? Then you have your cost of tools and your contractors. Well, as you drop the denied dollars in here and you estimate the time at a standard rate of FTE, right? Physicians are going to be higher than HIM and coding and others. But as you start to look at that, then you get a real dollar impact. When you do a really good job of quantifying this information and you take this back to a CFO or a physician leader, the practice plan leader, and you show them this has a very haunting impact on the way they think about denials, okay? It really can drive a lot of discussion because you've done an excellent job of monetizing the effect of these. It's not just the denial anymore, it's the level of effort that it takes to remediate the denial, okay? Next slide, please, sir. So this is the concept that I was talking about that a lot of my clients, when I go in, have not embraced and haven't thought of, okay? So we're talking about aging your payments and aging your denials. Everybody understands aging charges or aging claims because it's the date that was billed until today when we're looking at it. What I want you to consider is look at the amount of payment. When did you get the payment, okay? And then age that payment itself. Don't look at the receivable, age the payment. So in this analysis, and this is real client information, it's de-identified. But in this analysis, we see that this client is getting 68% of their payments within 30 days. Well, some people would say that's excellent. My response is, why aren't we getting all of it in 30 days? Okay, we're providing a service. If we've got everything configured the way we need to configure it, and our contract terms say that we should get paid within 30 days, why are we not getting paid within 30 days? What I would submit to you is in that 61 plus bucket down there, where 16% of the claims are getting paid after 60 days, you definitely want to trim that. You want to know who those payers are. You want to understand the services that are going through those payers that could be contributing to that situation. You want to be looking at those. I would not look at the ones that are under 30 days. There's no reason to. I'd be looking at 46 to 61 and developing and basically investing my effort into trying to get those into the 30-day bucket, right? Denial aging is another area. And you could see on this, because this is the same client, okay? The same client is having 24% of their denials are not being received until 60 days after. Why is that? Why are we so poor in getting the denial information and posting the denial information? Again, you would want to know who those payers are, and if they are consistent or they're frequent flyers in this bucket, then you might want to talk to your OGC about what you can do to fix this. Or should we even consider treating their covered individuals in this organization, given that they're so bad at, number one, paying us, and number two, denying things and denying them way late, okay? Just a different take on how you can work this and gather some information so you can find this hidden cash and remediate these problem issues. Next slide, please, sir. So here's our conclusion, okay? Analytics in identifying and gathering and recouping hidden cash, analytics should play a significant role in identifying your cash collection opportunities and understanding the cost benefit level of effort in order to gather them, okay? Again, we touched on a couple of topics there, outsourcing. We also talked about gathering a cost analysis to show the real impact of denials and adjustments when you've got to go back and work those. Point number two is risk ranking and using cost drivers provides the ability to make justified decisions. How many times have you been asked, well, why do you want to work on that first? Well, you've already got the answers there using the data, right? And when you put that data in front of them, it's very difficult for people to refute your justifications when you've got the data to back it up. I've got the game plan, I've got the data, here's what we're going to do, here's what we're going to implement to correct these problems. Point number three is identifying, tracking, categorizing, and assigning responsibility is an absolute necessity for prevention. If you don't know where it goes, How are you going to work it from month to month to month to develop that consistency so that it's really just an assembly line? I got this, it fell in this bucket, here's what I'm going to do, and here's what I'm going to get rid of. I always say this, we want to take the brain out of the process. We want it to be a reaction, and it's based upon the data. The brain comes in to helping actually solve the problem. It shouldn't be used to identify, track, and categorize. That's what you want to use the data and the technology to do. And finally, point number 4 is incorrect adjustment and denial prevention is the responsibility of everyone who's responsible from first patient contact to the final adjudication of the claim. Anyone that tries to deny that responsibility is not part of the solution, okay? So do those things like we talked about of identifying your champions and leveraging your champions and your small working groups to really have an impact on identifying and recouping this hidden cash. I think the next one is the last slide. Yep,
The last polling question. Last polling question. What technique can provide deeper insight into your organization's reimbursement history? Calling the payer, chanting and channeling, age payments and denials, none of the above. Great. Yep, C, aging payments and denials.
Very good.
C.
I think that's it.
Yeah, so thank you, David. It's 7 minutes before the hour, so it's good. We're good on time. So I know that we haven't had any questions in chat or Q&A, so I just wanted to open this forum to see if there's anybody, if you want to raise a hand, just put a question in the chat. But if not, we can always follow up with the email with questions, and we can address those offline too. Well, thank you everyone for joining us today. There is here, if you have any information, questions specifically, there's David's email, david.hullum, or as well as partner@rgphealthcare.com. We'll reach out to you. Again, please complete the survey. Thanks for your participation and have a great day. Thank you so much.
Thank you.